Okay, good afternoon, everybody. Welcome to this month's Soundbites episode. Hope everyone's feeling a bit cooler today after yesterday's heat wave. I'm really pleased to be joined this afternoon by our guest, Jo Lockwood-Smith. Today, Jo is a nurse consultant in major trauma. She's also a co-chair of the National Major Trauma Nursing Group. Jo, thank you so much for giving up your time. We were just saying how busy you are. Can you tell us a bit about your role as a nurse consultant and the kind of patients that you're caring for?
Yeah, sure. I've been a nurse consultant for about 3 years now. I've worked in major trauma for over 15 years. But my role basically covers four main domains. So I work clinically with patients. So I'll do MDT and I'll physically go and see patients. I'm actively involved and lead on research as well. So do some research pieces involved in major trauma. There's a leadership element to my job as well. So I manage a team of advanced practitioners. And then lastly, there's an educational component to it as well. So do a lot of teaching and creating a lot of e-learning modules and things that you guys have actually helped us with in the past as well. So the types of patients that we see are very varied, which is probably why I've been in the job for so long because we have that varied sort of patient group. So we
Yeah.
get lots of various mechanisms of injury. So lots of road traffic accidents, lots of things these days like e-scooters and
Yeah.
electric bikes. We get lots of occupational injuries. We get lots of interpersonal violence, often some self-directed violence as well. So lots of patients who have attempted suicide. And then we get more innocuous injuries like low-level falls, so like trips and slips. So lots of rib fractures, lots of older people tripping over rugs and coffee tables, for example. And the injury types for all of these patients can again vary quite dramatically.
Mhm.
So it's a literal top to toe. So it can be a head injury like we're going to discuss today. So traumatic brain injury, spinal cord injuries, orthopedics, plastics injuries, cardiothoracics, like I said, so lots of rib fractures, injuries, and then we've also got, like vascular and general surgical injuries from like road traffic accidents, so lots of blunt trauma. So
Mhm.
a literal top to toe, various different kinds of things.
So really varied and really busy. It keeps it interesting, doesn't it?
It does. It does.
Well, we co-authored an article, as you say, focusing on kind of brain injury in the Neuro Rehab Times earlier this year, and that kind of came out of a really interesting talk that Jo gave at our brain injury conference in Leeds, and I think was that last year. The time's going so
Yeah,
quick. I
has
think it was
been, yeah.
towards the end of last year, wasn't it? And Jo just had such a great perspective on, we obviously act for clients who've suffered traumatic brain injury. And one of the kind of areas we were discussing at that conference was challenging behaviour. And it was really interesting to hear from you, Jo, about obviously treating those patients kind of on the ward, and trying to manage those, really challenging behaviours in with some patients, obviously on an NHS ward. And, some of our clients are very fortunate and through the claim have interim payments that can fund, a private kind of neuro rehab facility where it might be quite calm and they've got their own room and there's kind of bespoke tailored rehab, but obviously for the vast majority of patients that is just not the environment that they're in at all, and I was really kind of struck by the examples that you gave of how clinicians can just make some adjustments to make that environment better for that brain injured person. And so that's what we kind of wrote about in the article that we did for Neuro Rehab Times. And you were very kind to give up some more of your time to us. You're regretting ever agreeing to do that first conference, aren't you? But to just to kind of bring that to life a little bit today for us. I mean, how do we define kind of challenging behavior after a brain injury? It's a bit of a kind of nebulous term, but there are kind of things that you see kind of time and time again and that you might expect to see following a traumatic brain injury.
Yeah, it's exactly that, Hayley. It is nebulous. And it's tricky to define because something that you might find challenging might be very different to something that I find challenging. I might, for example, find disinhibition and verbal aggression and swearing not particularly difficult to deal with.
Yeah.
Not casting aspersions on the fact that I'm Scottish, but someone who previously starts swearing at me, it's not really going to rub me up the wrong way, to be honest. But in the context of what we're talking about, I'd say that challenge of behaviour is any sort of behaviour that inhibits the recovery process, that something that's inhibiting the treatment and interfering with the recovery and the rehab, basically. And that might be something that causes harm, the patient's doing that causes harm to themselves, or it
Mm,
might be that they're causing harm to the caregivers, to the clinicians as well. And again, when we say aggression, that can be both physical and verbal. And I mean, I think when we say that people are physically aggressive, it's obviously really startling to think that patients assault us. They do, unfortunately, they do. But I personally, for me, I wouldn't say that it was worse than actually the tirade of abuse that can often come out of patients as well. So we can have both of those things. The
mm,
disinhibition, I would say, can be really tricky to deal with emotionally. So there can be lots of inappropriate behaviours, like in a social context. So like a distinct lack of filter. So there
mm,
might be someone who starts to use like racial language and racial slurs, and that might have been something that they would never have done before. It could be a
yeah.
complete 180 from their actual personality. Sometimes it isn't, but often it is, and their partners and caregivers and family will be disgusted by it
Yeah.
and really, really shocked by it.
Yeah.
And that can actually, for me, often be more upsetting than, the the sort of basic response of throwing a punch. For me, that can be often more because you just know that this isn't the person that you're seeing
Yeah.
in front of you. And again, something else that can be really difficult is the sexual disinhibition. So we get, female nurses make up 89% of the UK
Wow.
nursing population. So
Yeah.
often that sexual disinhibition can be quite tricky for our staff. They also, they tend to be, they tend not me anymore, but they tend to be quite young individuals who want to work in trauma. You have to
Yeah.
have a certain amount of get up and go and energy, and it is so very, very difficult. So younger females just being confronted by that sexual disinhibition can be quite tricky as well. And again, a bit different from the aggression. Also, apathy can be quite difficult to deal with as well, often just
Yeah.
as difficult if you've got a patient who won't engage at all in
Yeah.
any sort of therapy is quite difficult as a clinician to deal with because you're trying to get them to the next place. So, on
Yeah.
an occupational therapist, a physiotherapist, a dietitian, they might have no appetite whatsoever. You might not be able to get your patient to even eat properly. And that's
Yeah.
difficult because, as clinicians, we are tick box, do this, do that, like trying to progress people, trying to move people on. So that apathy is something that we don't often talk about when we're talking about a
Mm.
challenge in behaviour, but it really is one, especially for someone who's just trying to get their job done and do the best thing for their patients.
Yeah. Like you say, and do something that helps that patient. I think,
Yeah,
both of us, and I think, lots of people in this industry, they go into this kind of job because they want to help people and they want to, help them rehabilitate and recover and rebuild their lives. And like you say, it's not something that's, often necessarily included when we talk about those kind of challenging behaviors. But yeah, just that complete lack of engagement. can almost be significantly harder than a client who, engages 70% of the time, and then 30% of the time, is maybe dealing with, as you say, those more kind of typical challenger behaviors of,
Yeah.
the aggression, the violence, that sort of thing. Um, One thing that I thought was really interesting that kind of came out of the conference that we did and the talk that you gave was kind of a reframing of those challenging behaviors after brain injury, and that actually seeing that behavior as a means of communication for that patient. And I thought that was so important. And looking, actually taking a step back and thinking, well, what's the root cause of this challenging behavior? What needs is that brain injured person trying to communicate? Do you see, is there a kind of common thread or theme that you see in terms of those needs that might kind of preempt that challenging behavioral
Yeah.
episode?
Yeah, I'd say it is very difficult, as you've said, but any behaviour is communication for me. And this is not supposed to sound patronising at all, but I often, when I'm teaching, I often relate traumatic brain injury to dealing with a toddler. Now, you and I can both relate to this.
Yes.
And again, it does sound quite patronising, and it's not because I'm an adult general nurse, so I'm talking about adults. But those behaviours um, that a person is trying to communicate to you often is expressed as aggression, as we've said.
Mm,
It's often expressed as anger. That's a secondary emotion. It's not a primary emotion. So under that anger, you have to suss out what's causing the anger, and it's usually fear. It's usually frustration. But a lot of
mm,
the needs of the patient that they can't articulate to you are really basic. So I would always, if I had a patient kicking off, as someone will say, it's often these basic needs. So it's often elimination. It's often a toileting need.
right.
So
Yeah.
it's usually, I would say to nurses or anyone looking after this patient, do you know when their bowels opened last? Because often it's something because we are often dealing literally with punches getting thrown and just calming that patient down, we're often not thinking they need the toilet, they need to go to the
Mm,
toilet. Actually, we did manage to feed them yesterday. And even if you don't eat, this is often what people forget, your bowels still move.
mm.
You still pass mucus, etc., and things. Sorry to get right into the nitty-gritty of it, but there are basic human elimination needs that patients have that
Yeah.
often we don't think about.
Yeah.
And if your patient isn't mobile and they are unfortunately using incontinence pads, that would be the first place I went, to be honest,
Mm,
just to check an elimination need. Things like indwelling catheters, if the patient isn't mobile, isn't able to use a bottle to pass urine, or a bedpan, if it be a female, can you imagine what it would feel like if you hadn't had it to have a plastic tube going into your bladder? I mean, the amount
yeah.
of times that I've just seen a patient self, what we call a TWOC, a trial without a catheter, so a patient just rip that out of themselves, bearing in
Yeah.
mind they are inflated with 10 mils of saline. So you can
Gosh. Yeah.
imagine. But these really basic things are often triggers for patients.
Mm,
That as well as tiredness. And that tiredness can often come from overwhelm. So I would say if it's not the basic elimination needs, if it's not tired, if it's not hunger or toileting, then it's often just overwhelm. So you have to consider that your brain, when it's repairing, and it's trying to create those neural pathways again, when your brain is in repair mode, you need to rest a whole lot more than you or I do. So you
yeah.
actually don't be nervous about the fact that your patient has slept for 3 hours in the day. And often people do get anxious about that, and they'll be like, oh God, they'll be up all night, and the night shift team will be going mad because they'll be up all night. Their brain really require that nap time so they can be really tired and really easily overwhelmed by
Yeah.
just even things like meeting 10 people in a day. And
Yeah.
that would sound like it's not much, but if you consider the amount of people on a medical ward round. So the doctors, the nurses, the healthcare assistants, the speech and language therapist, the occupational therapist, the physiotherapist. Maybe there's someone from a different medical team who'll have to see them. Maybe they've got visitors.
Yeah.
10 people is easy,
And then
easily.
there's other people potentially if they're in a bay as well, isn't there? There's
Exactly.
other
There's other
patients who
patients,
have
there's other
needs and
patients'
visitors.
relatives, there's other patients' relatives who don't understand what they're going through and think that patient, oh my God, they're a nightmare. You know, they get really upset on behalf of their own relative who's in a bed space, maybe about, unfortunately, 2 feet away from theirs.
Yeah,
2 feet's being generous for some places.
yeah,
So, but if you think about the cognitive overwhelm and overload of having all of those people come to see you and you have to interact with them all, is huge. It's
yeah,
huge for them.
absolutely. And like you say, going back to those kind of basic needs as well, any of us who have had to spend even a short amount of time in hospital, they're always roasting. And I can't even imagine how warm it was on
Yeah.
the wards yesterday. They are hot. They're generally noisy. Like you say, they're busy. There's lots of kind of people coming and going, staff changing shift. And that is for anybody, that can be enough to kind of cause that dysregulation. Then you add on, a brain injury, maybe difficulties in communication. It's really not surprising, is it, that these patients that is their way to communicate these challenges. Um, what's something that if you were kind of, I suppose, with your kind of training hat on, what's something that clinical teams, who are in that kind of busy environment, it's the NHS, we can't just wave a magic wand and create this perfect sanctuary for each patient. But are there some kind of simple changes that teams can make that um, can have some benefits to, maybe a brain injured patient who's struggling with these sorts of things?
Yeah, I would say I would agree with what you've said. The environmental triggers are basically what we want to try and limit as much as we possibly can. So ideally, you do want your patient in their own room, and often um, especially if you've got a particularly aggressive or violent patient, often it can look externally like we're rewarding bad behavior by giving this person their own room because they are like gold dust. And that's obviously really, really false because the patient needs to be less stimulated and then it will cause less of a ripple effect for the
Mm,
team and for the other patients as well. So ideally being in their own room where you can control the volume, you can control the lighting. And by volume, I mean, like you've said, there are patient buzzers, there are buzzers to get in the door, there are telephones, there are just people, just teams, the amount of people who are there. Actually what I wanted to do before I did the talk for you guys in Leeds was actually just do an anonymous recording of what a ward sounds like because it's incredible. And we'll
yeah,
often laugh and talk about, if your patient's in a bay and not in their own room, these magic soundproof curtains that don't actually exist. You pull a curtain round the bed and then
yeah.
everyone
In
will
a
talk.
bubble. Yeah,
Yeah, you just talk really loud. You know exactly what's happening to the patient next door. They're not soundproof curtains.
yeah,
So the volume of actual people's voices just is incredible in the hospital environment. So yeah, ideally if they are removed from other patients for everyone's benefit, and if they do have their own room, it's tricky, like you said, Hayley. This is an acute NHS environments we're talking about. So those side rooms are used for infection control purposes. They can use
yeah.
for gender purposes. They can be used for, if we've got a patient who was assaulted or there was some violent safeguarding issue, literally to hide the person. So, these
Mhm.
side rooms are often scarce, but that would be a simple um, ideal way to look after the patient, I would say.
Hmm. And what have you seen kind of from your own experience with patients making those, environmental changes as far as you can, like you say, even if it's to do with lighting or like you say, just everyone on the ward trying to be aware of their like volume and the number of
Yeah.
visitors. What are the kind of direct benefits that you might be able to see with a patient who's been struggling with that challenging behavior? Is there a kind of direct benefit to them with these changes?
Yeah, I would say that I would say that we can often be really reactive to behaviour rather than proactive to behaviour. So if we get in early and we start these proactive strategies, then we are using less sedative medications. We're not using restraints. I mean, I personally hate them. I don't know if you've ever seen them. They're like boxing gloves, these hand restraints that
It's,
we put
aren't
on
they?
people
Yeah, they're,
sometimes,
yeah,
the mittens. I would argue and have argued and often do, if you have a one-to-one person looking after you, then you don't need a hand restraint. I'm sorry, like that person, often human touch is a really useful thing. Like hold that person's
hmm,
hand, give them a fidget toy. Often these things are really, really useful rather than just inhibiting someone from actual physical touch, which for me, it's just it can do the opposite of what it's intending to do. And I caveat that with, if there are tubes and lines and things, and if we're
yeah,
taking out NG tubes and reinserting them every 2 days, it's difficult. It is really difficult, but they are a cause of frustration in themselves. So I would certainly say if we don't have to do those things, if we don't have to, giving someone an IM sedative injection, reacting to their really severe behaviour isn't pleasant for the patient, and it's not pleasant for the
no,
staff who have to do it either. It's really emotionally distressing for the person who's
I can
having to
only
do it.
imagine. Yeah, yeah,
So if we're limiting those things, then obviously there are huge benefits to that. There are huge benefits to being as consistent as you can be with staff as well. So the staff, and
mm,
if the patients are used to the staff, you'll often find that there are just some good relationships are formed, good therapeutic relationships are formed. You have to be slightly careful with that because it's a very draining thing to be one-to-one with a patient for 12 hours. We work 12-hour shifts. And if you're one-to-one with a particularly aggressive patient, but then you gain that reputation as someone who's good with him, her, whatever, then you're
yeah,
just pop
yeah,
there every day. So
yeah.
that can be quite draining as well. But we do see some improvements with that, But I've had patients who've required and don't have a psychiatric background, but have required mental health nurses to look after them just because of the severity of their behaviours. And
Mm,
we've had one recently who required three mental health nurses per shift for their
wow.
safety and the safety of staff. Obviously, there's a huge cost implication for that. So I
Yeah,
think it's one of the reasons why, like the interim payments and things that you guys can get involved with are so hugely beneficial also to the NHS because often we get the patients to a point where we're not a neuro rehab facility, we are an acute
yeah.
NHS environment, and it's just we know that it's not the right place for them, and they don't know that yet. But
They
you
feel
will see, but they don't know it yet. But yeah,
it.
they'll get there. But
Yeah.
yeah, it's tricky. It's tricky to manage, and we do the best we can with what we've got,
Yeah,
essentially.
well, you do an incredible job, and I think just the number of things that you're having to juggle, like you say, on a major trauma ward, it's just mind-boggling. And I think it's really interesting that actually, when there is so much complexity and variety, as you say, that actually some of the most simple things can be the most effective. Like you were saying, like the temperature, the lighting, number of staff, the volume, and I really love that you said that being proactive in rather than reactive. And I think really, if as humans, we would, if we had to choose how we would care for, we would always rather have that, wouldn't we? We would rather have someone kind of doing that kind of assessment for us and trying to give us that safe space to kind of go through after a horrific injury or incident or illness. Having someone to proactively try and tailor that environment to you so that it can be calmer and a feeling of safety really, so that you can then do that recovery. We would all choose that, wouldn't we, over, like you say, the alternative, which is restraints, or like you say, medical sedatives. I just thought it was so amazing that actually, with so much complexity, that actually those simple things that are sometimes missed can be so, so important. We've spoken more about this in the article that I mentioned, and I will make sure that that's linked for anybody who wants to read it. But thank you so much, Jo. It was
Very
brilliant.
much.
I love hearing you talk, and your kind of passion for just providing that environment for your patients comes through. And yeah, just thank you so much for joining us. I really, really appreciate it.
Pleasure. Thank you.
Thank you.